and my task is to say how does the latest data inform the practicing surgeon. I do have some conflicts of interest. The one that's probably relevant to this is that I am pro-op CABG, and I do use Medtronic equipment, and I act as an advisor to that company. So, back in 2011, Volkmar Falk and myself were asked to write an editorial for Heart about what we thought of the relevance of NICE guidelines for off-pump CABG, and we said it was time to turn off the pump. But if you look at the recent studies that have been published in the literature, maybe we'd have to now change this to turn on the pump. And let me explain what I mean by that. So, as Ben said, about 16%, 17% of patients undergo off-pump surgery in the UK. Figures have increased, I think, up to about 20%. But the key thing to take away from that is that's not all of us doing 20% of our patients off-pump. That's most of us doing almost no off-pump surgery, and a lot of us doing very high volumes of off-pump surgery. So you have to be careful how you interpret that figure. And if you go to the Far East, for example, over 60% of patients are routinely done off-pump. In India, it's approaching 80-90%. It's also very important, as we've already alluded to this morning, that when we're talking about evidence basis for an intervention, we look at different types of evidence. And there is no question the randomised controlled trial is the gold standard because it eliminates bias. But it often has a large number of potential weaknesses. Small numbers of patients. They only include often a small percentage of the eligible population. So you actually end up in the randomised trial with fairly atypical patient populations. This is compounded by often short durations of follow-up, large numbers of crossovers. And if you look at the history of PCI versus CABG, of the 20 randomised trials, 19 of them fit into this category, the one exception being syntax, and we'll come back to that later. The other kind of evidence that we can look at, as Andrew Wexler referred to, are registries, particularly propensity match registries. The strengths of these are that they often have large numbers of patients, often tens of thousands of patients, and they actually represent what we do in real clinical practice. However, their major weakness is the potential for confounding or bias by factors that you may actually know about, but even more importantly, factors you may not know about. Now, if you look at the recent history of publications on off-pump surgery, for those who are pro-off-pump surgery, it's pretty depressing. First, the Ruby trial in the New England Journal of Medicine 2009, 1,100 patients in each group, and it showed that 1 year there was an increase in cardiac death and adverse composite endpoints in the off-pump group. Now, this was criticised on the basis that these were only included low-risk patients. The surgeons were often quite inexperienced. In theory, they had to have done a median of 50 off-pump surgery, but the entry criteria was only to have done 20. And if you worked out the numbers these surgeons were doing in this trial, the average surgeon in the Ruby trial was doing 7 off-pump surgery cases a year, so very low volume. And notice that 12% of off-pump patients were converted to on-pump. Now, in experienced off-pump surgeons, you would not expect to be converting 12% of your patients to on-pump. A second depressing paper for the off-pump advocates was this one in JTCVS. Off-pump coronary bypass may increase late mortality, a meta-analysis of randomised trials. So this was 11 trials, 4,500 patients with at least 1 year follow-up, and showing an odds ratio of death with off-pump surgery at 1.3. Again, but only looking at randomised trials. And then there was this paper, and I'm embarrassed to be one of the authors on it, off-pump or on-pump CABG bypass grafting at 30 days, published in the New England Journal of Medicine online on March the 27th. And when we looked at this, this was 4,752 patients. If you look at the primary endpoint for death, MI, stroke, and new dialysis, absolutely no difference between the groups. But if you look at the incidence of repeat revascularization and repeat revascularization was 0.7% in the off-pump group, 0.2% in the on-pump. So these are very small numbers, but as Andrew Wexler made the point, this became statistically significant. And the only obvious benefit for off-pump surgery was reducing the incidence of respiratory failure and renal injury. And now another rather depressing bit of evidence, if you're pro-off-pump surgery, is this Cochrane Analysis, published last week, or about 2 weeks ago now. And this is arguably the most definitive piece of evidence in the literature by Moller and colleagues. It looked at 86 randomised trials involving 10,000 patients. The op-CABG mortality was 3.7% versus 3.1% for on-pump, so a relative ratio of 1.24. The off-pump patients had fewer distal anastomoses, but note there was no significant difference in MI, stroke, renal insufficiency or reintervention, and CABG did reduce AF. Now, the authors of this paper went on to say, our systematic review did not demonstrate any significant benefit of off-pump compared with on-pump CABG regarding mortality, stroke or myocardial infarction. In contrast, we observed better long-term survival in the group of patients undergoing on-pump CABG with the use of cardiopulmonary bypass and cardioplegic arrest. Based on the current evidence, on-pump CABG should continue to be the standard surgical treatment. However, off-pump CABG may be acceptable when there are contraindications for cannulation of the aorta and bypass. But when you look at this Cochrane analysis, a couple of things to say. Again, this only looked at trials involving low-risk patients. The actual experience of the surgeons in many of these trials was not clear. So the conversion rates in some trials was 0%, in other trials it was 27%. And they define long-term survival as survival beyond 30 days. So again, a lot of questions about this paper. And finally, in their own discussion, they said, patients entered into the randomised trials may not be typical of all patients undergoing CABG. Mainly patients with low risk of post-operative complications have been enrolled in these trials, and patients with 3-vessel coronary disease and impaired left ventricular function are underrepresented. So you have to read, this document is 390 pages long, and it's on page 390 you find out that these patients may not actually represent what goes on in most clinical practice. And this type of paper is absolutely dangerous. It should have a health warning stamped across it that these findings are only relevant to a very small proportion of patients in randomised trials, but they are presented as a generalisation to our whole population. So, if the evidence is that there doesn't seem to be great benefit of off-pump surgery in the randomised trials, what happens in the real world? Well, this is a paper, the first on these, by Wasundara and Jack in 2005, compared 37 randomised trials and 14 observational studies. Now, in the observational studies, these were of propensity matched patients involving more than 250,000 patients. And they showed that the relative risk of death, MI, renal failure, less importantly, atrial fibrillation and transfusion, were significantly reduced, at least in hospital, for the off-pump surgery. But by 1 to 2 years, there was a slight increase in mortality. There was still a reduction in the relative risk of mortality at 1 to 2 years. This is a paper from New York by Hannon and colleagues looking at 14,000 off-pump, 36,000 on-pump, propensity matched for all the usual risk factors, and they pointed out that the off-pump surgery were a significantly higher risk population, suggesting that in New York, surgeons were beginning to do their higher risk patients preferentially off-pump. The off-pump did, however, have fewer grafts. And what they reported was the off-pump mortality, the 30-day mortality was 0.81, stroke 0.7, respiratory failure significantly reduced, but at 3 years, no difference in mortality, but a slightly higher repeat revascularisation with off-pump surgery. In this paper by John Puskas, looking at the STS database, they looked at 42,500 patients, analysed by 32 clinical risk factors. And again, what they showed, similar to the 2 previous large observational registries, were a reduction in death, CVA, MI, MACE, and length of hospital stay greater than 14 days. And in the most definitive piece of work, I would say, done yet, 38 propensity match studies of 123,000 patients published in JTCVS in 2010 for mortality, stroke, renal failure, prolonged ventilation, balloon pump, inotropic support, re-op for bleeding, blood transfusion and wound infection, all highly significant reductions with off-pump surgery. And they concluded off-pump surgery does indeed reduce all morbidity and most mortality in average clinical practice. And then Takagi, who had previously published the meta-analysis showing no benefit of off-pump surgery in randomised trials, then looked at 18 propensity match studies with 28,000 patients followed for 1 to 2 to 10 years and showed a relative reduction in mortality for off-pump surgery at 0.9. So they found different findings in real clinical practice from what they had found in the patients in the registries. And I think this may explain what's going on. This is from John Puskas' paper looking at the STS database called Off-Pump Surgery Disproportionately Benefits High-Risk Patients. And what you can see is that up to a predicted risk mortality of around 2.5%, there is no difference between on and off pump surgery. But as the predicted risk to the patient increases, then you have a plateauing in the effects of mortality for off-pump surgery, whereas the on-pump surgery mortality continues to increase with that that's predicted by the STS scores. And they concluded the survival benefit of off-pump surgery appears when the predicted mortality is above 2.5%, and that this survival benefit continues to increase as predicted mortality. But I find this a very interesting slide, because if I superimpose on this what happened in the trials of PCI versus CABG, the patients in those trials were all highly selected, and they fitted down in this lower left corner of the box, where the mortality in both the PCI and CABG patients was so low that there was no difference in mortality, and therefore this was then said by the cardiologist to prove that PCI was equally effective to CABG, and they then generalised that to the whole population. But if you look at what happens as you get into the higher risk patients, or the patients with more severe coronary disease, then you get this preferential benefit of CABG over PCI. Now, so how do we tie in what's happening with off-pump and on-pump surgery, the apparent discrepancy between the randomised trials and the large propensity match databases? In this editorial for the European Heart Journal, Doug Altman and myself wrote, indeed, this discrepancy between the apparent lack of benefit with off-pump CABG in randomised trials populated by low-risk patients versus its apparent benefits in high-risk patients enrolled in registries is analogous to the situation with stents and surgery for CABG. Earlier randomised trials, largely populated with patients with low severity coronary artery disease, showed no survival benefit of CABG over PCI, while in contrast, numerous propensity match registries containing patients with more severe disease and being more representative, therefore, of most patients requiring intervention, reported an important survival benefit of CABG over PCI. What else can we say about off-pump surgery? This is an analysis, a meta-analysis published in JTCVS last year, neurological complications after off-pump surgery grafting with and without aortic manipulation. Because many of us who do off-pump surgery say that the real benefits come not only by not cannulating or cross-clamping the aorta, but avoiding any aortic manipulation, so the top ends for vein grafts, and they showed a very significant reduction in the risk of cerebral injury if you use a true no-touch aortic technique. And that's entirely consistent with what we do know, that most strokes come from diseased aortas. What about graft patency? Well, this is again by Taggart, looking at a meta-analysis of graft patency of off-pump, 6 randomised trials, 1,000 patients, so not particularly big. Overall graft patency on versus off was 88 versus 85. But notice the difference between arterial grafts, where there was no difference in patency, versus a venous graft, where there was a marked reduction in patency. And this again was shown in the Ruby trial. Not everyone's agreed with it. So we asked the question, is there a genuine reduction in patency of vein grafts with off-pump surgery? And I think the answer is obviously is almost certainly yes. I think in the earlier stages of your off-pump surgery, it probably reflects technical issues. But what I actually think becomes more important once you're past that is that I think the major reason for a difference between the veins and the arteries, if it was purely technical, you would expect to see the same difference in arteries and veins. And I think what's happening is that with off-pump surgery, you're losing the antiplatelet effect of bypass. So if you do a patient on pump, you use aspirin and you use bypass, so you've got dual antiplatelet medication. If you do patients off pump, you've only got single antiplatelet medication unless you specifically institute dual antiplatelet therapy. So to summarise and conclude, I'd say that most randomised trials show that off-pump surgery reduces some aspects of morbidity, but are underpowered to detect any differences in mortality. And for the vast majority of patients undergoing CABG, I would say it's more important to use bilateral internal mammary arteries than whether you do them on or off pump. There are now several large propensity-matched observational registries of high-risk patients which have consistently reported that off-pump CABG reduces mortality, stroke, and overall most aspects of major morbidity. There is strong evidence of the ability to reduce the incidence of stroke with a no-touch aortic technique as part of off-pump surgery. And I think there is evidence of poorer graft patency with off-pump surgery, mainly affecting vein grafts, but there's some conflicting evidence about this, and there is still some uncertainty as to why that's happening. So on that point, I'm going to conclude my talk. I'd like to thank the Society again for the opportunity to give this talk, and you, the audience, for your attention. Thank you.
Thank you, David, for the usual eloquence. Thank you. One or two questions, perhaps. David.
The Cochrane review said the mortality was 3.7 versus 3.1%. These figures are quite high, aren't they? What was their mortality? How did they define their mortality?
They define mortality as those patients who died.
I know, but what I mean, 3.7% is a bit too high if it would look only at 30 days.
That's what it...
You can take it any way you want, but those are the figures they've come up with. I mean, those are taken from all of the randomised trials.
And what was their range?
I'm sorry?
What was the range of follow-up?
Well, they define long-term follow-up as the patients were followed for at least 30 days, which is not very helpful.
I don't know, but do you know how
no, it
long
doesn't.
It
It doesn't tell you what they should have said was what was the mean or median duration of follow-up. They don't tell you.
Okay, thanks.
Greatly enjoyed your talk. This is
Thank you.
Kunal Sarkar from Calcutta, India.
Thank you.
You did make a reference to the practice in India. It's true
Yes.
that it's very true that the overall incidence of off-pump is in the high 70s or 80%. But what is also very different is our understanding of our on-pump surgery. There is literally no use of any cardioplegic surgery, because when in the southeast and in the east, when you mean on-pump surgery, it's like on-pump beating heart for 90% of people. So there is another source of confusion. We are gathering some data of our own, which would probably come into the domain in a few years' time. But there is another source of confusion now as to what you actually mean by on-pump surgery.
Thank you.
Thank you.
Just a caution on that. We published a paper in Circulation, I think it was 2008, a randomised trial, where we let everyone thought the good thing to do is on-pump beating heart and avoid cardioplegia. And these patients would be 60 patients randomised, and we looked at two things. We looked at biochemical markers of injury, and all patients get pre- and post-op MRI scans. And to our surprise, what we found was there was more myocardial injury in on-pump beating heart than with cardioplegia. And when you looked at the MRI scans, what you saw was in the distal apical area, subendocardially, there were lots of little microinfarcts. And what we felt was the reason for this is that if you're doing them on pump beating heart, if you've got a mean perfusion pressure of 60 in your bypass circuit, by the time if you look at the pressure distal to maybe one or two stenosis in the LAD, then the perfusion pressure probably in the distal apex was probably maybe 10 or 15 millimeters of mercury. So we abandoned that technique. So it was counterintuitive because what we thought we were going to show was on-pump beating heart reduced myocardial injury. And Gianni Angelini's group then did a similar type of study and came up with pretty similar findings. So on-pump beating heart, now you get away with it because these are microinfarcts and what is their relevance over the long term, but there was definitely more myocardial injury with that technique.